So thank you very much for the opportunity to talk and chair a session. I have one disclosure. It has no bearing to this talk with Gore as a consultant. So I'm going to base this on a case, a patient that's average for me, 45-year-old patient, actually, with a history of severe obesity. If we're going to really talk about averages, the average BMI in our practice is 54.7, with type 2 diabetes, sleep apnea, hypertension, and gastroesophageal reflux disease, who comes to clinic to discuss bariatric surgery. She takes liraglutide for her diabetes and uses omeprazole daily for her reflux. If she doesn't use her reflux, she has severe recurrence of symptoms. On preoperative endoscopy, she's found to have LA grade A esophagitis and a small hiatal hernia. And so what surgery would you consider for this patient? And so kind of pros for a sleeve in this situation: it's low risk profile, or lower risk compared to the bypass, and no difference in diabetes remission depending on the literature you look at. Cons: there's an increased risk of worsening reflux, increased risk of Barrett's esophagus, concerns for an increased risk of hiatal hernia recurrence, and maybe less weight loss. What about the gastric bypass? It could also be considered in this case as well. What would be the pros? Better improvement or remission of diabetes depending on other studies. Treats reflux at the same time, potentially better weight loss depending on the studies you look at. And then cons: increased risk compared to the sleeve and increased vitamin deficiency, specifically iron and calcium after 5 to 7 years. And so kind of that average patient, what's the conversation I think about or what are the thoughts I have when I'm going through that history? And I designed that patient to go through the most common comorbidities that we think about related to obesity as a disease. And so which surgery is best for diabetes? We just tease that out for this patient. Well, interestingly, I used to think one thing and now I think something different. And so looking at a meta-analysis of 9 randomized controlled trials, where it totaled over 500 patients, there was actually no difference in diabetes remission between gastric bypass and sleeve at 1, 3, and 5 years postoperatively. Looking at SM-BOSS, which is one randomized controlled trial of 200 patients, it showed complete remission that was similar between a sleeve and bypass with, again, a non-significant p-value for difference. And then the sleeve pass, also a randomized controlled trial, demonstrated no differences in diabetes remission or improved glycemic control between the sleeve and bypass at 5 years. However, there are other studies that show, like looking at insurance claim data, that actually their patients were more likely to come off diabetes medications following a gastric bypass compared to a sleeve. And the Stampede trial at 5 years showed similar data, both at actually 3-year and 5-year data, that they were more likely to come off medications, but then when you looked at glycosylated hemoglobin, there was really no difference at 3 and 5 years. So in my head, the jury's still out on which is actually better based on the data we have. Well, what about sleep apnea? Actually, there's the least amount of data in sleep apnea. SleepPass and SM-BOSS demonstrated no difference in remission for sleep apnea between gastric bypass and sleeve. And there are really little data comparing the two. It's more described individually, but actually comparing the SleepPass and the SM-BOSS were the only things I was able to find, where if depending on what you look like, it's anywhere between 75 to 80% improvement or remission. What about hypertension? So SleepPass, again, that RCT demonstrated greater remission in hypertension for patients undergoing gastric bypass compared to a sleeve. But then when you look at a meta-analysis of 5 randomized controlled trials and increase that N to 478 patients, there's no difference. And then looking at a retrospective kind of large database study of 7,000 patients, there was also no difference in remission of gastric bypass and sleeve. And that Kaplan-Meier curve is the number of medications over time, or kind of our estimated remission based on coming off of medications, comparing sleeve to bypass, and you can see the curves are almost identical. And then the most controversial one, I think, is the acid reflux. So I went back and looked at a paper by Dupree and Matthew Martin that was published in JAMA Surgery, and it looked at laparoscopic sleeve gastrectomy in patients with acid reflux, and kind of it looked at actually the national inpatient sample. And overall, the number of patients who had severe reflux, which was considered a GERD score of 3 or higher, and it's not based on GERD-Q, it was actually a calculation that they made based on evidence within the chart. And they were comparable between the sleeve and the bypass from a prevalence perspective preoperatively. And postoperatively, actually, acid reflux was improved. It seemed like it was better with both the sleeve and the bypass comparatively. And so overall, it seemed like you got improvements with reflux with both. However, there was a higher cohort of patients that had no change in the reflux. with the sleeve. But interestingly, in this study, there was actually an area where it was potentially worse reflux with the bypass. And that's where, again, a database study is really challenging. Based on this, I got really confused. And so I kept looking. And so there were a retrospective series of 43 patients with pH testing. I thought that would be a much more objective measure of what's going on with reflux. 21%, this is preoperative pH testing, 21% of patients had a change in their surgical management based on pH testing, meaning we found pathologic reflux and they decided to switch from a sleeve to a bypass. And this is actually consistent, I know, with at least my data at WashU and at the data at University of Chicago that Vivek Prashant has described in previous meetings a couple of years ago. And then of the patients going through a sleeve, 14% had esophagitis postoperatively, so they continued to have true reflux and pathologic reflux postoperatively. And then looking at 23 studies combined, 6,000 patients, there was a 7.8% change in surgical management overall, secondary to EGD findings. So those findings preoperatively may be able to help you anywhere between 7 to 21% of the time, depending on what study you're looking at. So what do we do? Again, still very confused. So the ASMBS put together a position statement this year that was published in SWORD. The important things they felt based on the data is screen for reflux symptoms, and then preoperative EGD is a good thing to do even in asymptomatic patients because it can guide treatment and modify conditions prior to, meaning 7 to 21% of the time we may change our choice in procedure based on what we're seeing on the EGD. And then based on current evidence for reflux outcomes for gastric bypass and sleeve, patients with conclusive and objective evidence of preoperative reflux are better served by a bypass. And this data I didn't present, but there's small studies that show that's better to do a bypass than a sleeve in LA grade C and D esophagitis, meaning more severe pathologic reflux, or a total acid exposure time of greater than 6% on pH impedance testing. So then switching to just weight loss, BMI 42 is the one here, 54 if you're going to look at my average patient. If you look at a meta-analysis of 33 randomized controlled trials, there was a greater weight loss or a greater loss of BMI with the gastric bypass compared to the sleeve at 1 and 3 years. They went all the way to 5 years. At 5 years, there was no difference. And so, interestingly, while there may be a little bit of a trend towards increased weight loss with the bypass, that may not hold up long term. And this is the change in BMI or excess BMI loss from a different paper that shows actually at 1 and 3 years there's really similar weight loss compared to the two procedures. So which surgery? Actually, at this point, based on what I'm finding, either are reasonable depending on kind of the patient factors that you're considering, counseling, and how you want to approach the patient in the clinic. And you could argue, depending on the literature, you can make an argument either way for all different comorbid conditions specific to obesity as a disease. So are there factors affecting surgeon choice? So everything's the same, you're going to talk to them, or is one of us in the clinic or in the audience going to make a different decision than another person? Likely. And actually, this has been studied. You're more likely to undergo, or the thought with this one study looking at the MBSA-equipped database is a gastric bypass is more likely to be performed in patients with obesity-related comorbid conditions like diabetes, sleep apnea, reflux. But a sleeve is more likely to be performed in older patients or higher risk or considered higher risk comorbid conditions, heart disease, kidney disease, smoking within a year, COPD. In a retrospective evaluation of the New York database called SPARCS from 2007 to 2014, they were able to get some surgeon-level data, and there was a wide variation in what surgeons offered. But the surgeon factors affected choice of procedure more than patient and hospital factors when they looked at it on multivariate analysis. And interestingly, that study also showed that usually a surgeon picked one procedure and did it more frequently than any other procedure, and it wasn't consistent across the group of bariatric surgeons. So what technical considerations, if you're going to take that patient to the OR, should you consider? Because we wanted to talk about indications and also technical. And we could get into, I think, a nice discussion of what's important from a technique perspective. There's not a lot of data, so I decided to focus on the data coming from some video-based assessments that are coming out of Michigan's work. And so technical considerations in a sleeve, optimal technique, mobilize the fundus, How close should the stapler be near the pylorus from an outcomes perspective. The median in this group when looking at video-based assessment in Michigan was 5 centimeters. Lateral retraction of the stomach, meaning how much are you going to cinch this, the stomach down, or how much you're going to tighten on the bougie. What size bougie would you use? The median in this group was 36. Anywhere between a 32 and a 40 was used. Location of the stapler near the incisura, median was about 2.25 centimeters. Location of the stapler near the GE junction, meaning how close or far away are you going to be from the angle of His. Hemostasis of the staple line, spiral effect, and final sleeve gastrectomy width. And they looked at surgeon-specific data for a year and looked at 7,200 cases. And based on using these objective measures, they kind of created quartiles of technical success or technical expertise. And if they thought the best sleeves compared to the worst sleeves, there was a higher risk of complications, leaks, and reoperations and readmissions in patients who had the worst technique versus surgeons who had the better technique, which is kind of interesting. And these were the factors that they found were very important in this video-based assessment. And they did this similarly, actually, in gastric bypass patients. And so they've created kind of a scoring system, it's OSATs, or a validated training itinerary. And so for a gastric bypass, this is the list of things that are really important that we all think about when we do a gastric bypass. And similarly, the top quartile of surgeon skill, decreased risk of complications, readmissions, reoperations, and ED visits. So in conclusion, when looking at comorbid conditions and weight loss individually, there's a lot of variability, and you can make an argument, I think, in either direction. I used to think it was really one way or another, and it really isn't. Surgeon experience truly does affect your choice, and the primary goal, I think, really needs to be maximizing benefits and minimizing risks. Not all patients come in with this very standard vignette. And then focusing on the development of optimal skills, I think we using this previously validated kind of list may help improve our outcomes at 30 days following surgery. Thank you.